All right, so now we want to hear from one of our community leaders who's helped guide us through this pandemic. Dr. Virginia Caine is the Director and Chief Medical Officer for the Marion County Public Health Department. She's very passionate about inclusion in healthcare and will tell us what we need to focus on locally from a public health perspective. Dr. Caine, welcome.
Well, thank you. And I'd really like to thank BioCrossroads and this Life Summit for giving me this opportunity to talk to you about a subject that's really, I think, very critical for all communities. And that is, when we first looked at this COVID pandemic, one of the things that we were very surprised about were the vulnerable populations from a social determinant standpoint, their ability to access health care. You know, our hospital systems were overwhelmed with over like 2,000 cases occurring every day. And with people so sick from this, one of the messages that were going out to our people of color was, you know, unless you're very, very sick, please do not turn up in our emergency rooms because you may be exposed or at a higher risk for contracting COVID-19. And so we saw this message at the beginning of the epidemic, but then as things stabilized and we had much more control of this infection, we shifted our attention to the vaccination phase. And we were surprised at the significant amount of vaccine hesitancy that we were experiencing in our people of color. And I think one of those issues that was related to that is just highlights how critical communications and communications and the messaging that goes out to our populations that are vulnerable. And that is, now it's okay for you to come to our hospital systems for vaccinations, but initially you said, well, it might not be safe unless I'm really, really sick. So we can see these complications where it is so important from a cultural perspective, what resonates for which particular population that you are addressing. And one very major thing that occurred during this epidemic was that we saw new populations such as our homeless population, and we saw how many people because of this epidemic became homeless because of this pandemic, and yet how do they access health care? So I can go to an emergency room, I can go to an urgent care facility, but let's just say I have the flu and I need that 10 days of medication that will prevent this. You know, when you're having an overwhelming emergency room system, I get my prescription and I'm told that, you know, go and get this medication to help prevent you from succumbing to influenza. And yet I'm homeless, I've got no money, I don't have any mechanism to pay for this medication. These are the kind of things that when you have an overwhelmed healthcare system, you may not be paying attention to, and we find out that we may not get the same quality of care for our patients depending on that particular patient population. And you know, when this epidemic really took off, which was in our winter months, we had a significant number of those homeless populations who live outdoors because of mental health issues, felt very uncomfortable about being inside a building or a shelter. So if I have someone who's positive for COVID and then they're returning or are being placed in a shelter that may house over 1,000 individuals, then you have an incubating environment that will trigger a huge outbreak of cases if you can't go to a location where you're able to do social distancing of at least 3 or more feet. And so one of the recommendations we made early was, hey, I can't have you house 1,000 people in a homeless environment, okay? I can only allow you no more than 250 individuals at a time in a facility so that I can assure I've got social distancing of at least 6 feet, but definitely 3 feet. So the response I got was, well, where do we move all of these people? And you have to move them in a very rapid standpoint. So public health got into the business of providing homeless services. So opening up hotels, using staff to have to house and separate these patients who were positive for individuals who were not positive. But I also say, you know, we saw so many mothers with children who still have to go to school, you know, and how do you study and learn in that type of environment? And even places such as our prison systems, you know, where we saw huge outbreaks, fortunately not in Indiana, but states like Colorado, where over 2,000 prisoners got infected. What kind of policies did you have to put in place to make sure that you were safeguarding the prisoners who were remaining in these locations? So I think the biggest thing is, from a cultural standpoint, that we really saw diversity of our populations. You know, we have a significant Latinx population, African Americans, and maybe one of the largest Burmese populations in the country. And so when we received the feedback that people weren't understanding about where to go test it, how to do the vaccination, we were kind of surprised of the number of our diversity populations who could not even read. You know, we were patting ourselves on the back that, hey, I've got all this information out there, third grade information. You can sign up using third grade level information, and individuals could not even read. And so I think that's really highlighted the gaps that we had, and also not having enough people from a workforce standpoint, having people represented by the populations that we wanted to serve. So we really needed to understand that cultural competency in order to provide the services that we had. And the other huge thing is, look at the number of people who left the healthcare system from a workforce standpoint. We've had over 500,000 of our healthcare professionals who are no longer in the healthcare system business, because it's just the burnout that you see with our workers. Also the frustration of having to see a lot of people die when some of these instances might have been prevented by a higher rate of vaccinations in our community in order to bring up herd immunity. So I say that to say that it is so important to understand what kind of structures we have in place, and to recognize that the huge mental health impact that this created on our community, and that we have enough mental health providers able to provide the services. Our suicide rates went up. The depression was off the charts. And so when people lose their jobs or they're facing the stress of being evicted, you know, what kind of support have we provided related to this? And then, you know, we are a new environment now. You know, we have all this remote learning that you have to do. And so our kids are going to school, but our populations that are vulnerable, how many of them have internet access? You were talking about, we went into the telehealth field and providing more services related to that, but did I have the ability as a senior to be able to do telehealth? So did I see a lot of services that our populations didn't receive because of our stay in shelter policies and recommendations, my lack of ability to talk to my provider, but we continue to have a substantial number of our population who don't have access to a primary care provider. And so how do you do the education related to this? So one of the critical pieces that we had to learn is, and as our earlier speaker alluded to, we have to figure out how to get those resources to those social networks of the people we want to reach. And our Mayor Hotsett for the city of Indianapolis, in partnership with the Marion County Public Health Department and a New York organization called Results Saving Lives, have put out $1 million in little mini grants to help do that education about vaccine hesitancy, to do that education about where to go for testing, and have to provide more mobilized health treatments to where people live, where they reside. We have to start to learn how to value them, and as a result of that, it's so critical to establish these critical partnerships. And we have to learn that population-based strategies are going to be so critical in the near future in order for us to have successful health outcomes. So that partnership between public health and healthcare systems are just so critical, I believe, in making a difference in our health outcomes. But the diversity and inclusion of the services that we offer will be huge. And I will follow up by saying that you have to work with the trusted messengers of people in these communities. And you have to have the ability to communicate. So we must continue to address implicit bias in the dealings that we have with vulnerable populations. People may not be aware that they may be insulting someone, or they may not have any credibility when they're communicating with someone. I'm the diabetic pregnant mother, and I'm having my provider tell me, well, you know, you should do better in taking care of your blood sugar. It's too high. And you know, you're not eating properly. Well, yes. So I'm in a food desert, doctor, okay? I had to get on a bus for an hour to even make it to another grocery store. And just how many groceries can I carry to get back to my place where I reside? So until we have an better understanding of the people that we are serving, you know, your communication to me is going to go out one ear, out the other, because you don't even understand my lifestyle in order to help make realistic and logical recommendations for me and to put those resources available in order for me to have an improved health outcome. And so until we can get to that point, we will continue to have major challenges. And I say, hey, Mr. Murphy, other people in the healthcare systems, we got to change the paradigm of how we provide health care. We've got to do transformational changes in our health systems. We've got to get away from those relative value units and focus more on value-based care. Only then will we be successful. Thank you.
Dr. Caine, thank you so much, and thank you for your leadership, especially through the pandemic.